Imagine going to the doctor with this sudden stabbing pain right in your reproductive organs. Or, maybe a constant burning urgency that makes you feel like you have a severe infection.
Right. It's terrifying.
Yeah, exactly.
Yeah.
So you do the logical thing. You go in, you take round after round of antibiotics, you get all these expensive scans, you endure, honestly, incredibly invasive and painful exams.
And then the doctor just looks at you.
Right. After all of that, they sit you down and tell you that structurally, chemically, you are perfectly healthy.
Which is almost worse to hear.
It really is. They tell you there's no infection, no tumor, literally nothing wrong with your organs. But you are still in absolute agony.
And for decades, patients in this exact scenario were just told it was all in their head.
Like they were just making it up. But it turns out you're not crazy. You are actually suffering from a hidden epidemic of physical tension, and the culprit isn't a failing organ at all. It's a muscle you didn't even know you had, basically pulling a neurological trick on your brain.
It is the ultimate medical sleight of hand, really. And I mean, it's one of the most frustrating, isolating experiences a human being can go through.
Absolutely.
Because our entire medical system is just built on this idea that if something hurts, well, the problem must be located exactly where you feel the pain.
Right, which makes sense normally, but not here.
Yeah.
Welcome to the deep dive, everyone. Today, we are wading into some deeply misunderstood biological waters.
Yeah, we really are.
We are looking at this paradigm-shifting approach to chronic pain, specifically looking at the Wise-Anderson protocol. And this is a framework that was originally detailed in a medical text called A Headache in the Pelvis.
Fascinating read, by the way.
Oh, completely mind-blowing. Our mission today is to entirely remap your understanding of the lower half of your body. We're going to look at how the human pelvis acts as this, hidden reservoir for daily stress, how it physically clenches to protect you, and how that very protection can trap you in this cycle of relentless pain.
And we're going to unpack the actual mechanics of that pain down to the cellular and neurological level.
Because that's where the magic is.
Exactly, because once you understand the machinery of it, it stops being this mysterious curse and it becomes a mechanical problem, one that you can actually solve. We are shifting the blame away from mysterious organ failures and pointing it directly at a hidden web of muscle tension and, well, psychological stress.
Right. So if you are listening to this right now, maybe you're sitting in office traffic or hunched over a laptop, I want you to just pay attention to your body for a second.
Do a quick scan.
Yeah, exactly. Are you pulling your tailbone in slightly? Are you clenching your jaw? Are your stomach muscles tight? Because that exact unconscious tension you are holding right now is basically step one of a terrifying cycle.
It's the spark.
Yeah. And to understand how that tension turns into agonizing pain, we really have to start with a concept the protocol calls the symptom threshold.
I love this concept. This threshold model is absolutely brilliant because it perfectly illustrates the whole idea of invisible accumulation.
Right. The stuff you don't even realize is building up. So they map out 4 distinct levels of proximity to this symptom threshold. Let's try to really visualize this for everyone. Imagine your capacity to handle stress and tension is just a tall glass sitting on a table.
Okay, a glass of water.
Yeah. So level 1 is the baseline. The glass is empty. You have 0 symptoms. Your muscles are relaxed. Your nervous system is calm. You're just, happily living your life.
But I mean, realistically, hardly anyone in the modern world lives at level 1 permanently.
Right. Maybe on a really good vacation.
Yeah.
But most of us are hovering at level 2. And at level 2, the glass is filled with water just a single millimeter below the brim.
It's dangerously close.
Exactly. But to the outside observer, and honestly even to you, the glass looks completely fine. The water isn't spilling over yet. You have absolutely no pain. But physically, your tissues are flooded with latent tension.
Yeah, your muscles are tight, your nerves are just primed, and you are hovering right underneath that threshold of agony.
What is actually happening in the body at that point? Because if I don't feel pain, I assume I'm fine.
Well, this is where we need to look at the tissue itself. At level 2, you might not feel pain, but your muscles are operating in this state of low-grade, constant contraction.
Like they're just always slightly flexed.
Right. And when a muscle is constantly contracted like that, it actually restricts its own blood flow. It's a condition called ischemia.
Ischemia.
Okay. Yeah. So the tissue isn't getting enough oxygen, and metabolic waste products like lactic acid are just slowly building up in there. The alarm bells haven't really started ringing in the brain yet, but the environment is basically soaked in lighter fluid.
Wow. Which perfectly explains that whole out-of-nowhere phenomenon.
Yeah, exactly.
People constantly say, I didn't lift anything heavy. I didn't fall. I bent over to tie my shoe, and suddenly I was in crippling pelvic pain.
Right, they blame the shoe tying.
But if you are at level 2, the addition of just one single drop of water, like a bad day at work, a really stressful email, maybe a poor night's sleep, or, yeah, just tying your shoe, it causes that completely full glass to finally spill over. You cross the threshold.
And that realization, I mean, that is a massive psychological relief for people suffering from chronic pain. Because the pain feels so arbitrary and chaotic to them.
It feels like your body's just betraying you randomly.
Exactly. But understanding that you were silently hovering at level 2 for all that time, it removes the mystery. It wasn't the single drop of water that caused the flood. It was the fact that you've literally been living with a dangerously full glass for years.
Which brings us to level 3. The water has finally spilled over. You are slightly above the threshold. And this is a state where symptoms wax and wane.
The roller coaster phase.
Yeah, you have good days and bad days. The water sloshes over the brim. You feel a massive flare-up of pain. And then maybe you relax over the weekend. The water evaporates just a tiny bit, and the pain recedes. It's just exhausting.
It is. Until you eventually reach level 4, which is chronically symptomatic.
The worst level.
The worst. The tension is so deeply ingrained at this point, and the tissue is so starved of oxygen and completely riddled with trigger points that you are living continuously above the threshold. You are just locked in pain 24/7.
Wait, okay. I want to stop there for a second and just play devil's advocate, or at least ask the question that I know someone listening is thinking right now.
Go for it.
How exactly does a person go from just having a stressful job to having a medically locked up pelvic floor?
Yeah.
I mean, we all get stressed out. Why doesn't everyone hit level 4?
That is the core of the issue right there. And it comes down to what the protocol identifies as the self-feeding cycle of pelvic pain. It is essentially a closed neurological loop. And to really understand it, we kind of have to look back at our evolutionary biology.
Okay, take us back. We're cavemen now.
Right, so step 1 of this cycle is anxiety and worry. When a mammal is threatened, say a small dog is suddenly frightened by a much louder, larger dog, what is its immediate physical response?
It tucks its tail between its legs.
Exactly. It pulls its tailbone forward and up. It guards its vulnerable, soft underbelly, and it instinctively clenches its pelvic floor.
Oh, wow.
Yeah, it is an ancient, hardwired biological response to protect the most sensitive, vital organs from a predator. And guess what? Humans have that exact same hardware.
But our predators aren't wolves anymore.
Precisely. Our predators are unpayable bills, relationship trauma, and just relentless career pressure.
So we are sitting at our highly ergonomic office chairs, reading an anxiety-inducing email from our boss, and our biological hardware is literally tucking our invisible tail between our legs.
Yes. We pull the pelvic floor up and tight, and we hold it there for 8, 10, 12 hours a day.
I mean, that just sounds physically exhausting.
It is incredibly exhausting, and that leads directly to step 2 of the cycle. That chronic daily tension blocks the tissue from ever healing. Think about clenching your bicep as hard as you can.
Okay.
Now imagine keeping it clenched for 3 weeks straight.
Oh my gosh, my arm would fall off. It would be in agony.
Exactly. The muscle fibers would develop this painful, non-pathological soreness.
Non-pathological meaning like there's no actual disease there.
Yeah.
No bacteria, no virus, just pure mechanical exhaustion.
Right, precisely. The tissue is sore simply because it's been overworked to the point of structural failure. And here is where the trap really snaps shut. Step 3 is reflex protective guarding.
Reflexor guarding.
Yeah. When the body senses that the pelvic muscles are that sore and irritated, the nervous system panics. It thinks there's a major injury. And what does the body do to an injured area?
It tries to stabilize it, right?
It casts it. It immobilizes the area by clenching the surrounding muscles to protect it from further harm.
Oh, no, wait. So the muscle is sore because it's clenching, and the body's brilliant solution to fix the soreness is to clench it even harder.
Yes. It is a terrifying biological glitch.
That's horrible.
It really is. It's a neurological reflex, honestly no different than pulling your hand off a hot stove. But in this case, the perceived threat is the muscle itself. So the muscle guards against its own pain, which generates more pain, which then sends a signal back to the brain saying, hey, the pelvis is under attack, which of course generates more anxiety and worry.
The loop is completely closed. The anxiety tightens the muscle gets sore, the body tightens the muscle to protect it, the pain increases, and the brain gets even more anxious. It's just a self-generating engine of misery.
Exactly.
But I do want to clarify something because I feel like this is a really sensitive line to walk. Is this all in the mind? Like, are people just worrying themselves into phantom physical agony.
I am so, so glad you brought this up because we have to be incredibly clear here. The pain is undeniably deeply physical. If a physical therapist examines these specific muscles, they are literally knotted. They're inflamed, and they are extremely tender to the touch. It is real tissue damage and real nerve irritation. But, and this is the key, the engine driving that physical reality is the psychological software.
The brain.
Yes. The brain is basically holding the remote control that's sending this continuous clench signal down to the pelvis. You cannot separate the software from the hardware here. It is a very real mechanical injury caused by an emotional state.
That is a fascinating distinction. So if the threshold and the cycle explain the why and the how, we desperately need to figure out the where.
Right, the geography of it.
Because if the hardware is glitching, where exactly are these physical knots located? And this brings us to the internal landscape of the body and a concept that I honestly think is going to blow people's minds: referred pain.
Referred pain is basically the concept of neurological sleight of hand. It is the reason so many of these conditions are misdiagnosed for years and years.
Explain how that works for us. Because if I stub my toe hurts. The geography of pain seems pretty straightforward normally.
Usually it is very straightforward, but when we are talking about chronic tension, we are dealing with what are called trigger points. A trigger point is this hyper-irritable, incredibly tight knot within a taut band of muscle. It's like a localized traffic jam of muscle fibers that just refuse to let go.
It's just totally seized up.
Exactly. And these knots emit intense chemical signals. Now, all the nerves in your lower body have to travel up through the spinal cord to tell the brain what's going on, right?
Right.
Well, in the dorsal home of the spinal cord, many of these nerve pathways essentially converge.
Oh, like a bunch of cables plugging into a single internet router.
That is exactly it. And when a massive constant pain signal comes in from a hidden muscle deep in the pelvis, the signals can effectively cross over at that router. The brain receives the alarm, but it misinterprets the origin. It thinks the pain is coming from a completely different location along that shared nerve pathway.
Even if that other location is totally fine.
Yes. Often it points to an organ or a body part that is perfectly 100% healthy.
Wow. It's like pulling a loose thread on the hem of a sweater, and the collar up at the neck starts to pucker. The problem looks like it's at the collar, but the actual mechanical cause is way down at the hem.
That is a perfect analogy. You feel the pucker at the collar, but no amount of ironing or fixing the collar is going to solve the issue until you finally let go of the thread down at the hem.
So let's look at the hems of this issue. Let's map out these specific trigger points. The protocol highlights a massive muscle group deep inside the pelvis called the anterior levator uni.
Yes.
This is basically the muscular floor of the pelvic bowl, and it is broken down into these distinct portions, and each one basically plays its own vicious trick on the brain. Let's start with the superior portion, the puborectalis.
The puborectalis acts like a sling around your rectum. It's obviously vital for bowel control, but when it locks up into one of these trigger points, the referred pain pattern is just astonishing.
Yeah, the protocol notes that if you have a trigger point here, the pain refers straight to the tip and the shaft of the penis in men. It can also cause this deep, agonizing sensation of pressure and fullness in the prostate, or even refer pain directly to the bladder and the urethra.
Just imagine the diagnostic nightmare of that. A patient goes to a urologist complaining of severe pain in the tip of the penis and a swollen, heavy feeling in the prostate. The logical traditional medical assumption is a bacterial infection of the prostate, or maybe a really bad urinary tract infection.
So they prescribe a massive dose of Cipro or some other really heavy antibiotic.
And it does absolutely nothing.
Because there were no bacteria.
Right. The prostate is fine. The urethra is totally fine. The actual culprit is a knotted muscle sling located high up in the rectal cavity, squeezing a nerve and throwing a phantom pain signal forward.
It's genuinely tragic when you think about the psychological toll of that. People taking drugs that wreck their gut biome for a phantom infection.
And it just continues down the muscle group.
Yeah, the middle portion of this group, the levator prostate, refers pain to the base of the penis, the bladder, and it explicitly recreates frequency and urgency.
Frequency and urgency, the desperate, constant feeling that you need to urinate right now, even if your bladder is completely empty.
That sounds like torture.
It is. The muscle spasm physically irritates the nerves that supply the bladder, tricking the brain into feeling a false sense of fullness.
Yeah.
You are trapped in the bathroom feeling like you have the worst UTI of your life, but your urine cultures just keep coming back totally clean.
Then we reach the inferior portion of the anterior levator ani, the part closest to the back of the pubic bone. And what I found so illuminating here is how the protocol maps this exact same muscle across both male and female anatomies.
Yes, this is crucial.
It proves this isn't just a men's health or women's health issue. It's a fundamental human musculoskeletal issue.
The underlying hardware is exactly the same. The manifestation just shifts slightly based on the external geography.
Right. So in men, a knot in this inferior portion refers pain to the perineum, the area between the genitals and the rectum and the base of the penis. But in women, this exact same knotted muscle refers pain to the bladder, the urethra, the clitoris, the vaginal lips, and the vestibule, which is the entrance to the vagina.
And think about the profound shame and fear that comes with severe unexplained pain in the clitoris or the vaginal entrance. Women with these symptoms are so often told they have mysterious vulvar diseases or, horribly, that they just have psychological intimacy issues.
Which is so dismissive.
They undergo excruciating biopsies. But the protocol reveals that this highly localized, terrifying pain can be traced back to a treatable shared muscular root.
Okay, we have to talk about one of the most bizarre, visceral symptoms detailed in this entire deep dive. It's a phrase that comes up repeatedly in literature, and honestly, if you haven't experienced it, it sounds almost comical. But for the people suffering from it, it's just maddening. The feeling of having a golf ball in the rectum.
It is an incredibly specific yet universal descriptor among these patients, and it highlights exactly why traditional imaging just fails them.
Right, because if a patient tells a doctor, hey, I feel like I have a golf ball inside me, the doctor is immediately going to order an MRI or a CT scan. They are looking for a literal physical mass, like a tumor or a cyst.
But the scan comes back completely clear. There is no mass.
So how on earth does a muscle spasm mimic a solid object like a golf ball?
It comes down to two specific muscles, the coccygeus and the obturator internus. Let's look at the coccygeus first. It's a small muscle that helps form the back part of the pelvic floor, and it attaches right to the tailbone. When it goes into a severe spasm, the tissue actually becomes incredibly dense. It physically bulges inward.
Okay, so it does change shape.
Yes. At the same time, the spasm alters the local nerve feedback. So your brain perceives this really dense, bulging, hypersensitive knot of muscle as a foreign object taking up space in the rectal cavity.
Wow. And the protocol also notes that people with trigger points here experience intense pain right before or after a bowel movement, which again tricks the patient into thinking they have a digestive disease like IBS or some sort of structural bowel problem.
Exactly. Now, the other major culprit for that golf ball feeling is the obturator internus. And I have to say, this muscle is absolutely infamous in the world of pelvic pain.
Why? What makes it so uniquely bad?
Geography, mostly. The obturator internus is a large fan-shaped muscle that basically plasters the inside of your hip bone and then routes out to attach to your femur, your thigh bone.
Okay.
But crucially, as it passes through the pelvis, it runs intimately close to the pudendal nerve.
And the pudendal nerve is like the main nerve supplying the entire pelvic floor and genitals, right?
Exactly. It's a massive critical communication highway for the lower body. So when the obturator internus gets tight and develops a trigger point, it physically thickens and bears down right on that pudendal nerve. It compresses the highway.
Which causes a massive traffic jam of pain.
It causes a dull, relentless ache, a severe burning sensation throughout the entire pelvic floor. And in women, it is explicitly highlighted as a primary source of severe burning vulvar pain. Because the pudendal nerve branches out to the vulva, compressing it way up at the hip muscle, makes the vulva feel like it's literally on fire.
It's that sweater thread analogy again. You're pulling at the hip and it hurts at the vulva.
That's totally right.
Speaking of geography, there's a really fascinating mechanical detail in the sources about the tailbone, the coccygeus. The protocol notes that if a doctor or a physical therapist palpates the tailbone and finds that it is immobile, meaning it doesn't have that slight natural flex to it that it should have, it can actually perpetuate all of these pelvic pain trigger points.
Think of the tailbone like the central anchor point for a tent.
Okay.
All these pelvic floor muscles, the levator ani, the coccygeus, they act like the ropes securing the tent, and they all tie directly into that tailbone anchor. If that anchor is locked up, calcified, or structurally frozen, it changes the tension on all of those ropes.
It pulls everything out of alignment.
Yes, it forces those attached muscles to work in a completely unnatural, strained way, which just maintains that state of chronic tension we discussed in the self-feeding cycle.
Okay, so we've mapped these internal knots. We know the hardware is glitching. We know where it's glitching. The big question is, how on earth do you fix it? because we are talking about deeply hidden, highly protected, incredibly sensitive internal anatomy.
We are.
But the protocol provides these precise, almost mechanical descriptions of internal treatments.
And we really have to acknowledge right here how daunting this is. The vulnerability required for a patient to undergo or even self-administer internal pelvic physical therapy is immense.
Oh, absolutely.
But when you look at the mechanics of the actual treatment, it is pure applied neurology.
Let's break down the sphincter ani stretch.
Hmm.
The sphincter is obviously a circular muscle, and when it holds trigger points, it causes direct, agonizing anal pain. The protocol describes a very precise clock face method to release it.
Because it's a circle, it's about systematically releasing the radiotension. You can't just stretch it randomly in any direction.
Right. It says you apply a gentle stretching motion from the inside. First pressing upward toward the 12 o'clock position, holding it, then moving sideways to the 3 o'clock position, then downward to 6 o'clock, and finally sideways again toward 9 o'clock.
What you're doing mechanically there is triggering the Golgi tendon organs.
The what?
Golgi tendon organs. These are tiny sensory receptors within the muscle that sense changes in muscle tension. When you apply slow, sustained, highly specific pressure to a contracted muscle, you are essentially short-circuiting the reflex arc.
Okay.
You are forcing the muscle spindles to physically lengthen, and you're sending a brand new signal to the brain that says, hey, it is safe to release this tissue.
It's like you're coaxing the nervous system to finally stand down.
Precisely.
And that coaxing is even more apparent in the methodology for internal prostate massage. Now, when people hear prostate massage, they might have all sorts of associations, but this is a strict clinical technique for releasing hypertense tissue.
The cadence and the direction of the pressure are absolutely vital here.
The protocol maps it out so clearly. You locate the prostate, which sits just in front of the rectum, and you perform lateral sweeps. You start from the outside edge and move to the center lateral to medial. You sweep one side, then the other side. Then you sweep from the top of the prostate to the bottom, superior to inferior.
And why do you think it must be so incredibly methodical?
Well, because if you just poke a hypersensitized, guarded muscle, the body's reflex is going to be to clench even harder.
Exactly.
The protocol explicitly warns that if the prostate area is excruciatingly painful, the practitioner must be overwhelmingly gentle. The entire duration of this targeted sweeping massage is only about 1 minute.
Think about it. You are trying to convince a terrified guard dog to go to sleep. If you make sudden, aggressive movements, the dog bites.
Right.
But if you apply firm, predictable, soothing pressure in one consistent direction, the nervous system eventually realizes there is no real threat, and it finally lets the muscle melt.
It makes perfect sense. But here's the massive plot twist of this entire deep dive. You would think that doing all this internal work would be the end of the story. You stretch the sphincter, you release the levator ani, you untangle the obturator internus, the internal knots are gone so the pain stops.
Right.
In a simple machine, yes, but the human body is a continuous web of tension. So what happens when a patient does months of this incredibly painful, vulnerable internal therapy, and the symptoms just keep coming back anyway? The protocol reveals that the internal muscles might just be victims of a culprit located completely outside the pelvis.
Imagine the pelvic floor as a canvas hammock. We've been talking about the threads of the hammock itself getting knotted and tight. But what if the massive oak trees that the hammock is tied to are crooked?
The hammock is going to twist no matter how much you try to smooth out the canvas.
Exactly. And those trees are the massive external structural muscles of the legs, the hips, and the back.
Let's talk about these external trees. The protocol literally calls out one muscle as the great deceiver. It's called the adductor magnus, and it is explicitly described as being missed by many clinicians.
The adductor magnus is the secret ringleader in so many of these cases. It's an absolutely massive muscle that runs down your inner thigh. From an evolutionary perspective, this muscle is crucial for stabilizing your pelvis when you walk or run. Its main job is to pull your leg inward.
But when you sit all day or you cross your legs tightly at your desk for hours, that muscle gets shortened and completely locked up.
Right.
And when the adductor magnus develops trigger points, the referral patterns are devastating. The protocol notes that it refers pain deep into the pelvic floor, the perineum, the rectum, and the vagina. It's even another hidden source for that phantom golf ball in the rectum sensation.
And what's particularly tricky about the inner thigh causing pelvic pain is how the patients actually perceive it.
They don't feel it in their thigh.
Mostly, no. They don't say, my thigh hurts. They describe a deep, generalized internal pelvic ache. They can't pinpoint a specific structure. It just feels like the entire pubic bone or the core of the pelvis is throbbing.
And it gets even more complicated when we introduce the pectineus muscle, which is another inner thigh and groin muscle. The protocol highlights this as a major source of groin pain. But the biomechanical trap here is fascinating. It explicitly mentions a behavioral trigger, sexual activity, that involves vigorous squeezing of the thighs.
This is a really devastating cycle for patients. Squeezing the thighs together forcefully engages and locks up the pectineus. The muscle spasms, and because of exactly where it sits, it refers intense pain directly into the groin, the anterior thigh, and the labia.
So purely musculoskeletal action, literally just flexing your thighs, causes referred pain that feels exactly like localized genital or reproductive organ pain.
Yep.
No wonder it takes people years to get properly diagnosed. They're seeing gynecologists when they should be seeing biomechanical specialists.
It's a huge blind spot. Let's move around to the back of the hammock now, the gluteus muscles. We culturally think of the glutes just as our buttocks, maybe for aesthetic reasons or just for sitting, but their influence on the stability of the pelvic floor is immense.
Massive. Let's look at the gluteus maximus, the largest one. When this muscle develops a trigger point, it covers the entire lower sacrum in pain. And the physical sensation described in the protocol is just evocative and, honestly, terrible. It says that sitting on a hard seat feels like a nail is pressing into the sits bone.
The sits bone, the ischial tuberosity, is that bony prominence you feel when you sit up straight on a hard wooden chair. A knot in the gluteus maximus violently pulls on the connective tissue that attaches directly to that bone.
It causes restlessness, extreme pain in the tailbone, and it flares up immensely when sitting for more than 15 minutes or doing activities that heavily engage the glute, like walking uphill or swimming the crawl stroke. And this leads to one of the most practical, yet totally counterintuitive warnings in the entire protocol.
Oh, the famous donut pillow disaster.
Yes. Okay, if you feel like a nail is pressing into your tailbone every single time you sit down, logic dictates that you should sit on something that has a hole in the middle, a donut pillow. You take the physical pressure off the bone.
Right. It seems perfectly logical.
But the protocol emphatically states that patients must not use a donut pillow. Why is that?
Think about the actual physics of a donut pillow. When you sit on a flat surface, your weight is distributed across your glutes and your sits bones. When you sit on a donut pillow, you remove all structural support from the center of your pelvis. So gravity pulls your pelvis down right through the hole.
Like a heavy bowling ball placed on a trampoline.
Exactly. And what happens to the fabric of the trampoline? It
Oh.
stretches outward. By letting your pelvis sink into that hole, you are actively stretching and tearing at the gluteus maximus and the pelvic floor muscles from the outside in.
Oh, wow.
You are forcing the surrounding tissues to bury your entire upper body weight in an incredibly unnatural shear force vector. You are literally feeding the trigger point exactly the tension it thrives on.
That makes so much sense when you explain it like that. You think you're resting the bone, but you're actually just ripping the muscle. Instead, the protocol insists on an upright sitting posture, on a soft, supportive surface, avoiding slouching at all costs. It also advises these patients to sleep on their unaffected side with a pillow placed firmly between their knees to keep the hips parallel and offload tension from the glutes.
And we really cannot forget the smaller, hidden gluteal muscles underneath the maximus, the gluteus medius and the minimus.
The referral sites for these are genuinely shocking. You have a knot deep in the side of your hip, in your buttocks, and where does the pain shoot? Straight down the leg and incredibly straight into the testicles in men or into the vagina in women.
Again, the neurological router just gets confused. The nerves passing through the hip girdle share pathways with the nerves feeding the reproductive organs. You sit crooked in your car for a 3-hour commute. You kink the gluteus minimus, and your brain tells you your testicles are in agonizing pain.
It really is a house of mirrors, and the deceptive wiring extends even further up into the core. Let's look at the lateral abdominals, oblique side stomach muscles. The protocol notes that trigger points here can refer pain to the whole stomach, up into the ribs, down the groin, and once again is an important source of testicular pain.
The abdominal wall and the pelvic floor operate mechanically as a continuous pressure cylinder. Think of an inflated balloon. If you squeeze the top of the balloon, the abdominals, where does the air pressure go?
It forces it all down into the bottom of the balloon, the pelvic floor.
Exactly. If your abdominal wall is chronically tight, it is constantly driving downward pressure onto the levator ani, forcing it to work overtime just to keep your organs inside your body. The floor exhausts itself trying to fight the ceiling.
Which is exactly why doing 100 crunches a day might be the absolute worst possible thing for someone with pelvic pain.
Without a doubt.
Let's move around to the spine. The perikinals and multifidi muscles in the low back. The protocol makes a very specific distinction here to separate this from a standard bad back.
Right. If you pull a muscle lifting a heavy box, you usually feel a broad, fanning ache across your lower back. But referred pain from these specific multifidi trigger points does not fan out. It is tightly contained. It feels like a localized, intense, burning spot of pain right near the spine, often referring downward.
Finally, in our tour of the external hammock, we have to look at the iliopsoas. This is a massive, deep core muscle that connects your spine to your legs. Trigger points here refer to the anterior thigh, the groin, and the labia, but the mind-blowing connection here is to the digestive system.
The iliopsoas sits incredibly deep, directly adjacent to your colon and your intestines.
And the protocol notes that when a patient is merely constipated, the simple biological act of passing stool can trigger severe pain from the iliopsoas.
It perfectly illustrates how mechanically packed the abdomen really is. If you are constipated, your bowel physically expands. That expanded, rigid bowel presses directly against a hypertense, inflamed iliopsoas muscle. The muscle gets bumped, the trigger point fires, and it shoots a lightning bolt of pain down into your groin or labia.
So the patient naturally thinks, passing stool hurts my genitals, I must have a horrific internal disease. But in reality, a full pipe is just bumping against a tight wire.
Exactly. It's a proximity issue.
Okay, we have covered a massive amount of ground here. We've mapped the internal knots, we understand the threshold and the psychological cycle of anxiety, and we've exposed the external culprits hiding in our inner thighs, our glutes, and our abdominals. But a map is only useful if it helps you find the way out.
Right.
How does the Wise-Anderson protocol actually tell a patient to disarm these trigger points? How do you physically break this relentless neurological loop?
This is where the protocol transitions from being a diagnostic map into active mechanical rehabilitation. You have to physically intervene in your own muscle tension to force the hardware to basically reboot.
Let's talk about stretches and release tools. The protocol outlines highly specific stretches, but as we've learned, you aren't just blindly stretching. You are targeting the exact stubborn muscles we just discussed. Let's start with the pectineus stretch, that inner groin muscle that locks up when you squeeze your thighs.
The biomechanics of this stretch are designed to isolate a very difficult, hard-to-reach area.
The protocol states you lie down flat on your back on a firm surface. You bend one knee, keeping your foot planted on the floor, while your other leg rests straight out. Then you place your hand on the inside of the bent knee, and you slowly, gently push that knee outward, dropping it toward the floor. You hold that stretch for 15 to 30 seconds.
By using your hand to push the knee out, you are manually forcing the pectineus to lengthen. And by holding it for 30 seconds, you are outlasting the muscle's initial stretch reflex. You are telling the nervous system, hey, we are extending this tissue and nothing is tearing. It is safe to stay long.
Then there is the stretch for the adductor magnus, the secret ringleader of the inner thigh. For this one, you stand and stretch the affected leg out, resting your foot on a stool. You then slightly bend the knee of your standing leg, the one on the ground. By bending your standing knee, you lower your center of gravity, which dynamically increases or decreases the stretch on the inner thigh of the leg resting on the stool. You hold it for 30 seconds or longer.
But, and this is huge, the protocol includes a massive, bolded clinical caveat right here.
Yes, it explicitly warns, do not do this stretch if any pain in the knee is experienced.
It's a stark reminder of that interconnected web we talked about. If your adductor is so incredibly tight that stretching it causes the tension to pull on your knee joint ligaments instead, you have to stop immediately. You do not trade pelvic pain for a torn meniscus. You have to listen to the joint and back off.
What I found really fascinating looking through these movements is the explicit integration of ancient movement practices. The protocol literally includes the cobra stretch, acknowledging it directly as a well-known yoga pose.
It's a brilliant integration, really. For the cobra, you lie face down on your stomach, place your hands flat on the floor near your shoulders, and slowly push your upper body upward by straightening your arms, arching your back.
Which totally opens up the anterior structures. It stretches that abdominal wall we talked about, the ceiling of the pressure cylinder, giving the pelvic floor room to finally breathe.
It takes a holistic, thousands of years old movement practice and applies it clinically as a mechanical lever to break the tension cycle.
There's also a great standing stretch for the quadratus lumborum, or QL, which is that deep lower back muscle, and the hip abductors. You simply stand with your hands on your hips and you cross one leg in front of the other. Pushing your hip out to the side stretches that entire lateral fascial line. But as good as stretching is, stretching alone just lengthens the entire muscle. Doesn't always break up the localized knot, right?
Right. Stretching a muscle with a severe trigger point is sometimes like pulling on a knotted rope. The rope gets longer, but the knot just gets tighter. To truly deactivate a stubborn trigger point, you need direct, sustained ischemic pressure. You have to press directly on the knot to temporarily starve it of blood so that when you release, a massive rush of fresh oxygenated blood flushes out all those inflammatory chemicals.
Which brings us to the external trigger point release tools.
Yeah.
And I love that the protocol starts with something you can literally find in a dog park: a tennis ball.
It is the most accessible, perfectly dense medical device in the world.
The protocol describes using a tennis ball to release the trigger points in the gluteus minimus, medius, and maximus, the muscles causing that agonizing sits bone pain and the phantom testicular or vaginal pain. You simply place the tennis ball between your buttock and a wall. You lean your weight into the ball, rolling slightly until you find that precise, excruciating knot.
When you hit it, it feels like a very localized deep bruise.
And then you just lean in and hold it. It allows the patient to self-administer deep tissue pressure precisely where it's needed, manually overriding that faulty nerve signal.
But a tennis ball is soft and it's blunt. For the deeper, more complex anterior muscles of the abdomen, the protocol introduces a highly specialized tool they developed called the trigger point genie.
Yes, the genie. It's used to reach trigger points deep in the quadratus lumborum, the rectus abdominis, your six-pack muscles, and the iliacus. But we have to pause here, because we need to acknowledge the sheer vulnerability and the psychological barrier of what the protocol is asking a patient to do.
It is asking the patient to take a hard, visible tool and press it deeply into their own soft stomach, right into their internal organs.
And the protocol does not take this lightly at all. It issues one of the most severe clinical warnings in the entire text. When using the trigger point genie for abdominal release, it states in no uncertain terms that it's very important not to put undue pressure against the aorta in the middle of the abdomen.
The aorta is the main artery carrying highly oxygenated, high-pressure blood directly from your heart down through your torso to feed the lower half of your entire body.
It is a massive vital vessel.
Yeah.
And the text is so serious about the danger here that it insists an instructing supervising physical therapist must sit down with the patient and show them exactly where their aorta is. It's generally located in the midsection, slightly to the left in the abdomen. The therapist must physically teach the patient how to navigate around it and avoid putting any pressure on it whatsoever.
This specific warning completely underscores the medical reality of what we are discussing today. These stretches and releases aren't just feel-good, surface-level spa massages. This is deep, powerful physiological manipulation. You are digging into the literal core of your body to manually override a faulty, panicked nervous system. It is effective, but it requires deep respect, immense precision, and absolutely requires professional guidance.
So we've gone from the mind to the muscles and back again. Let's zoom out and look at the whole picture here. What does this deep dive really mean for the person listening right now?
We started this journey with a concept that feels kind of abstract, a psychological cycle of anxiety and worry. The idea that daily stress slowly fills a theoretical glass of water until the symptom threshold is violently breached.
From there, we traveled deep into the anatomical weeds. We explored the complex, hidden internal landscape of the levator ani and the prostate. We learned how localized muscle knots can masquerade as terrifying organ infections, pulling a profound neurological trick on the brain.
We then ventured outside the pelvis, discovering the biomechanical plot twist. We learned that the hammock of our pelvis is at the mercy of the trees, and that our glutes, our inner thighs, and even our abdominal walls can secretly sabotage our internal organs, referring pain to our most sensitive, vulnerable areas.
And finally, we found that there is a mechanical way out of the maze. By understanding the hardware and using precise stretches and tools like the tennis ball and the trigger point genie while safely navigating our major arteries, of course, we can physically press the reset button on our panicked nervous system.
If there is one singular insight to take away from this entire protocol, it's that the human body is a profoundly, unavoidably interconnected web. Whether you suffer from the specific agonizing syndromes outlined in this text, or if you simply sit at a desk all day clenching your jaw, rounding your shoulders, and tightening your abdomen as you read emails, You are accumulating tension. You are filling the glass.
Yeah.
And unchecked mechanical stress will eventually demand a physical toll.
It really makes you rethink the way we live. I mean, if our pelvic floor, the literal base of our human structural core, reacts to modern psychological anxiety by clenching up to physically guard us against a predator,
Huh.
it begs a massive question.
What's that?
Are the chronic, mysterious pain epidemics of the modern world simply the result of our ancient biological hardware not knowing how to process the stress of the 21st century?
Are we just breaking down because our bodies don't know what an email is?
It's a profound thought. We are walking around with software meant for survival in the wild, trying to run it in a cubicle. It's the ultimate tension between the world we evolved for and the world we actually live in. We started this deep dive talking about broken arms and X-ray machines. We talked about how comforting it is when the diagnostic picture is clean, when the doctor can point to a jagged white line and say, there is the exact problem. But maybe the muddy, confusing waters of pelvic pain aren't a sign that the body is broken in a way we can't understand.
Far from it.
Maybe it's a sign that the body is doing exactly what it was perfectly designed to do over millions of years. It is violently protecting us. It's just doing it at the wrong time and from the wrong threats. And the ultimate cure isn't a magical pill or an exploratory surgery or an antibiotic. The cure is the long, hard, mechanical process of teaching the body that it is finally safe to let go.